Hotbed Talk.
Good afternoon. I'm a perioperative physician and a critical care physician from Southampton in the UK. I lead the perioperative medicine service, which includes a cardiopulmonary exercise testing service, a prehabilitation service, and pre-optimization and shared decision-making clinics. I also lead the surgical high dependency unit, and as such, I'm able to look after surgical patients both before and after their operations. I'm also an optimist, and I see the preoperative period as a window of opportunity. It's a chance to intervene at a time when patients are particularly receptive to medical advice, facing what might be a potentially life-altering or life-changing event in the form of major surgery. It's a unique teachable moment where we may be able to affect change to long-term health outcomes as well as to improve their short-term surgical outcome. And it's a moment when we can also act to optimize the management of their chronic health conditions. So as perioperative physicians, I feel we should be optimists and see this as an opportunity to improve our patients' health outcomes in the longer term. In this session, we're going to talk about the importance of fitness, frailty, and function in perioperative medicine. I'm going to mainly focus on fitness, but I hope that I can convince you that these are both overlapping and interrelated concepts. And what is key in perioperative medicine is the multimodal evaluation and needs-based intervention on our surgical patients. So this is the challenge that we face as perioperative physicians. It's a patient population, as you know, that is aging in the Western world. In the UK, about a quarter of patients will be over the age of 65 by 2034. With the improvements in surgical technique and perioperative care and indeed anaesthetic techniques, surgery itself has become increasingly safe. And consequently, with this aging population, the contribution of patient factors is becoming increasingly important. Because we know that as patients age, they gain more and more comorbidities. And so we need to weigh up more carefully the risks and benefits of surgical intervention in a population whose life expectancy may in fact be limited by their comorbidities and not just by their surgical disease. And as a consequence, where the quality of remaining life is very important to the patient. As clinicians, this sort of data should give us cause to pause for thought. As you can see from the Marmot review from the UK, which looked at the determinants of health status, in fact, the majority of determinants of health are outside the remit of traditional medicine. Health behaviours, as you can see, determine about 30% of current health status. And I would suggest that we should start to consider addressing these behaviours as part of our core remit in healthcare. And this has recently been recognised by the NHS with the Making Every Contact Count campaign, where we try and address these behaviours every time we speak to a patient. Now, I think we're all familiar with the worldwide obesity epidemic. Globally, as of 2015, the World Health Organization declared that more people, for the first time, die in countries where obesity is more common as the cause of death than malnutrition. And I think there's always the assumption that obesity is caused by Western diet and excess calorie intake. But the effect of the other side of the energy balance is often underappreciated. And I want to talk to you about a different global pandemic, and that is that of physical inactivity, which on every metric is increasing globally and has continued to increase for at least the last 20 years. In the last Global Activity Survey published in 2012, it was estimated that over 5 million deaths worldwide annually are caused by lack of physical fitness and lack of physical activity. It's thought that 1 in 3 adults across the world are insufficiently active. Looking at the UK in particular, you can see that unfortunately we're leading in Europe in terms of rates of inactivity, and these have reached more than 40% in women and almost 40% in men. And if you want to worry yourself about the future and the future health of your children, it appears that over 85% of adolescents in the UK undertake insufficient physical exercise. So this is really an important global problem, and that is why it has been recognized as the World Health Organization as a pandemic and as a target, as one of public health's best buys, reducing physical inactivity by 10% by 2030. And so does this really matter? Yes, it really does. And I'm going to suggest and present some data that clearly makes this point. So if we look in the UK and in Europe, there is a concept of the population attributable fraction of a disease. And what this means is how much of any given disease is caused by a particular factor. And as you can see from these statistics here, up to nearly 20% of colorectal cancer and over 17% of breast cancer in the UK is actually caused by lack of physical activity or unfitness. And this is not a problem that's limited to the UK or indeed Europe. As you can see around the world, significant chronic health disease is caused by being unfit. And I think if you speak to patients, the majority of them are aware of the link between heart disease and lack of exercise, but less are aware of the direct link between the risk of cancer, in particular colon and breast cancer, and lack of exercise. And if you're not persuaded by the chronic disease impact of lack of physical exercise, the economic cost is also huge. Given that the UK has the highest levels of inactivity across Europe, in terms of direct effects of inactivity, it's estimated that we spent over 1.9 billion euros in 2012 dealing with the effects of physical inactivity. And there are a number of indirect effects. For example, unfit individuals have higher rates of mental health issues, and so mental health costs also increase with an inactive population. And when you sum these indirect and direct effects of inactivity in the UK, it's estimated to have cost us almost 15 billion euros in 2012. And the increased burden of chronic health disease also leads to increased mortality. So there is lots of data from all races that have been looked at and in both sexes that suggests the less fit you are, the more likely you are to die. And as you can see in this slide, there's an important trend, which is that you can see the greatest gains in longevity are when you move from being very unfit to a little bit less fit. And I can assure you that the surgical population, certainly from where I am in Southampton, is firmly on the left-hand side of this graph. So unfit individuals who have high risks of mortality. And there is this concept of the 15% reduction in mortality risk per Met increase in physical activity. So if you increase your oxygen consumption by the amount that you are currently consuming as you sit watching this video, so if you add that to your maximum oxygen consumption at peak exercise, over your lifespan, that would be associated with a 15% reduction in mortality. And I would challenge you to think of a medication that you've prescribed in the last year or 6 months that has had that impact on patient outcome. And how is it that fitness affects health outcomes? Well, as I've already alluded to, being unfit increases the incidence of chronic diseases. We've talked about cardiovascular disease, cancer, diabetes. There's also a 30% increase in your risk in dementia. But if you have a chronic disease, it also reduces or worsens your outcome from that disease. Both acute illness, cancer, heart failure, and ischemic heart disease. Really importantly, as a message for patients, however, is that it is never too late to change your behavior. So if you change your behavior from being unfit to fit, you also change your healthcare outcomes, which is one of the suggestions, one of the reasons why I believe this is not just association data, but there is causation between lack of physical fitness and these health outcomes. Importantly, also, you cannot rely on fitness in childhood for the rest of your life. So this was a prospective study that I'm showing here from Blair, published back in the 90s, showing a follow-up of 10,000 individuals in the Aerobics Centre longitudinal study over 5 years initially, and then up to 18 years with long-term follow-up. And those individuals who changed from unfit to fit had much reduced mortality overall. So what about fitness in perioperative medicine? Why is it important? It's important because we can use fitness to evaluate the functional impact of the patient's chronic comorbidities. It also allows us to evaluate, when we evaluate fitness objectively using cardiopulmonary exercise testing, which is the most important factor that's limiting a patient's function. And by knowing the fitness prior to the operation, we can help to predict that patient's immediate short-term outcomes after surgery, which we can use for risk counselling and shared decision-making to inform the decisions about where we should manage patients perioperatively. I think it's important to remember that fitness is a functional outcome. When we talk about fitness or functional capacity, we sometimes use those terms interchangeably. There are a number of definitions if you look across the literature. A very narrow definition used often in cardiology is that fitness or functional capacity reflects aerobic exercise capacity. A more functional definition is that functional capacity or a patient's fitness can be described by their ability to perform the activities of daily living or their job. But the important thing about fitness is that it takes together all of the patient's health behaviours, i.e. how much exercise they do, what they eat, and combines that with their comorbidities. So if they have underlying heart failure, they may be less able to exercise, and also the importance of psychological factors and self-efficacy, which affect whether you may engage not only with exercise training, but also with your perioperative care and treatment. So fitness is useful in perioperative planning because it combines all of those separate factors into a single variable measured as VO2 peak or exercise capacity. Unfortunately, assessing exercise capacity or fitness can be quite difficult when we do it subjectively by asking patients. I think we're all quite good at identifying the incredibly fit individual who still goes for a run every day and the incredibly unfit individual who's wheelchair bound. The challenge is that the majority of our patients fall somewhere in between, and when we ask patients about their fitness levels, they do not make the best witnesses. So on this slide here, on the left here, you see on the x-axis is what we measured with an objective fitness test, and on the y-axis is what the patient told you about their fitness. And as you can see, the two are not very closely related. And from the MET study published in The Lancet a couple of years ago on the right, you can see if you look on the y-axis is what we measured as a patient's exercise capacity, and on the x-axis you can see there's a huge spread around what the patient says. If the patient thinks they're fit, they may in fact be very fit or very unfit. And that's why we use cardiopulmonary exercise testing as a means of objectively evaluating fitness prior to surgery. This allows us to, gives us a continuous variable, which is a measure of aerobic fitness, and also allows us to look at limiting factors in terms of either underlying cardiac disease or respiratory disease, or maybe just deconditioning from lack of activity that are limiting the patient's fitness. It gives us continuous variables that we can look at in combination with other risk variables and other risk factors to predict a patient's outcome. And is there any evidence that fitness predicts surgical outcome? Well, this is the first data that was published early in the 90s by Paul Older's group from Australia in general surgical patients, looking at the relationship between anaerobic threshold and elective mortality. And he demonstrated that elective mortality was much higher in patients who were unfit and below an anaerobic threshold. The patients with an anaerobic threshold of 8 or less had a 50% perioperative mortality in this case series. Subsequent to this data in the ensuing 20 years, we have published more than 40 case cohort studies, which I'm not going to go through in detail. These are usually small-ish, single-center observational studies, but have all confirmed, or in the vast majority, that there is an association between preoperative fitness measured objectively with cardiopulmonary exercise testing and postoperative outcomes in terms of both morbidity, complications, and short and long-term mortality. So if fitness predicts short-term surgical outcomes, this begs the question, should we intervene preoperatively to try and improve a patient's fitness and thereby improve their outcome after surgery? And here you can see a graphical representation of this concept. If you look on the y-axis, we have functional capacity. And for an individual patient, independence is clearly hugely important. Patients agree to undergo elective surgery on the basis that we are either going to improve the quality of their life or how long they live. And so if we render a patient who walks into hospital with complications, as in the dotted line here on this slide, into somebody with a complicated recovery who never returns to their baseline and ends up being discharged to a nursing home, although the operation may have been a success, that's a failure for that individual patient. And the idea of preoperative exercise training, or prehabilitation as it's sometimes referred to, is to, prior to the surgery, improve that patient's functional capacity such that if they do, when they have a drop around the time of surgery, which is will always happen, they are nearer the baseline and so have less risk of getting complications that render them below the line of dependency, and also will improve the speed of their outcome and the return to a good baseline quality of life. So do exercise interventions improve outcome for patients after surgery? So there is a lot of work going on in this field currently, both with exercise interventions alone and what we call multimodal prehabilitation, which will be discussed in other sections of the conference, looking at the effects of both fitness and nutrition and psychological optimization on the patient prior to surgery. But the first randomized prospective trial looking at exercise interventions in a high-risk patient group was published 2 years ago now in Annals of Surgery. And in this study, patients who were ASA 3 or 4 and more than 70 years of age were enrolled in a high-intensity interval training program which was supervised preoperatively, along with some motivational interviewing and nutritional optimization. And the study demonstrated a reduction in post-operative complications of 50%. And the subsequent follow-up to this study has shown that there was also a reduced rate of readmission after surgery, and really importantly, in terms of long-term impact on health outcomes, there was sustained change in behavior in the patients at 6 months. And this was associated with the trend towards a reduction in cost and no increase in cost of that patient's care. So the preoperative prehabilitation program was paid for by the reduction in postoperative complications. And I want to focus a little bit, we're going to hear about frailty in the next talk in greater detail, on the overlap between fitness and frailty. If you look at the two main types of frailty definition you can see here on these slides, function in terms of fitness, slow walking speed, reduced grip strength, which are both elements of fitness, are part of the frailty phenotype definition. And if you look at the frailty index approach to defining frailty, this looks at symptoms from patients' comorbidities and combines that with the effects of those comorbidities on their function. So frailty itself incorporates both functional capacity and fitness. And so it's a tool which combines those. And I think really this emphasizes the really important point that preoperative evaluation should be multidimensional. We don't want to purely look at a patient's fitness. Their comorbidities are also important, as is their nutritional state, and also their frailty if it is present. So some patients are frail without having physical inactivity or being unfit, and equally some patients may be fit but they may be cognitively frail, for example a patient with early cognitive dysfunction or dementia. So preoperative evaluation and in fact optimization needs to think about not just fitness but also frailty. And it is worth noting that in terms of interventions to counteract frailty, exercise programs which may improve surgical outcomes have also been effective in reducing frailty in some small studies. When we think about looking after patients in perioperative medicine, it's really about patient-centered care. It's about making the right decision for an individual patient and making sure having had an individualised risk assessment and a shared decision-making process, that patient is in the best state for that operation. And that means optimising their physical fitness as well as their psychological and metabolic state, as well as making sure that their chronic health conditions are well controlled. And if we manage this in the preoperative period, they are more likely to have a rapid recovery to their baseline state or even to an improved state. In order to achieve this, as perioperative physicians, we need to think about how we screen patients, and then when we identify patients at risk, either with poor physical fitness, cognitive frailty, or poor nutritional status, we need to evaluate them and identify the best intervention package for that individual patient on the basis of their individual needs. And so that patients don't proceed to surgery without having either their comorbidities or their healthcare behaviours, including their fitness, optimised. And I want to leave you with this thought, which is that care pathways don't always promote patient-centred care and allow us to evaluate patients in a timely fashion so that we can optimise both their fitness and their chronic health conditions before their operation. Many of our pathways are actually clinician-centred. They're longitudinal, and often perioperative physicians or anaesthetists only have contact with the patient after the decision to have surgery has been made, and sometimes even only days to weeks before the operation, even though we've known that an operation is likely to happen in the cases of patients having neoadjuvant chemoradiotherapy for maybe several months. As we try to improve the optimization and prehabilitation of patients before major surgery, we also need to think about designing our patient pathways in such a way that we can screen them early for these comorbidities and frailty, and so intervene to improve their outcomes. And then I hope that we will deliver truly patient-centred perioperative care. Thank you for listening.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.